To introduce Dr. David Collins. He's board certified in neurology. I'm not going to go through everything because it is up there, but certainly this is very impressive. BS from the University of California, Santa Cruz, pathology pre-doctoral fellowship, University of Kansas School of Medicine, practice MD at the University of Kansas School of Medicine, internal medicine internship, University of California, San Diego Medical Center, neurology residence at the University of Southern Cal, LA Medical Center. He was also a chief resident there. Neuromuscular Disease Fellowship, also at the University of Southern California. Summit Medical Center, active staff in neurology, one of us. Alta Bates Medical Center, Berkeley. Courtesy staff in neurology, San Francisco Neurologic Society from 2002, Board of Directors 2000 present, and President 2011 to 2012, Director of CME 2012 to 2015. He's also involved with the Touro University School of Medicine in Vallejo, clinical instructor from 2005 to 2011, and assistant professor of neurology from 2011 to the present. He's chief neurology medical management team for Hill Physicians Medical Group, or was, 2011 to 2018. He's been practicing in the East Bay since 1993. Dr. Collins' current practice focuses on dementia, Parkinson's disease, MS, and neuromuscular disease. With all of that, I'm actually thrilled to be able to invite Dr. Collins up here for his presentation.
Well, thank you for that introduction. Actually, all of that, none of that's the interesting stuff. I actually had a mime troupe when I was in college. That's far more interesting. Thanks, Amy. Where did she go? For asking me to do this. Amy asked me to, can you do update and advances in neurology? And I said, do I have a full week to talk on that? So, neurology is a very big topic, which scares off a lot of medical students. Neurology throughout the country is sometimes having trouble filling their spots because medical students are very intimidated by it. It's very, very complicated. So I said, well, I'm not going to do an update on neurology. I'm just going to focus on the brain. That should only take me 2 or 3 days to cover. So buckle your seatbelts, everybody. How do I, let's see, is there, I guess, okay. All right, yeah, no, I have no disclosures here. With, all the list of things, I still measure my worth by how my patients are doing every day. And some days I'm good, and some days I'm not so good, but I try my best. So what we're going to do today, I'm going to talk about where we are. If you're not a neurologist, you may not be aware of all the cool stuff that's going on in neurology these days. And it's new things every week. 20 years ago, neurology, they said, oh, well, you can diagnose things, but you really can't treat anything. And that's just not the case anymore. We have a lot of treatments for things that we never used to have. And in the past, a neurologist was known as the great diagnostician because you could examine a patient and you could tell exactly where in the nervous system the problem was, and there were all these famous professors that were well known for their diagnostic skills, and then MRIs came along and they weren't so smart because it turns out that, oh, they thought it was here, but the MRI shows it's actually here. So diagnostic things are very important, and we've got better diagnostic tools. We don't have to guess as much as we used to anymore as to what's going on with the patient. And I'd say the most common brain diseases that we see. I'm not talking about spinal cord diseases or peripheral nerve diseases or muscle diseases, which we treat all of those as well. Alzheimer's disease, Parkinson's disease, multiple sclerosis, epilepsy. None of these are rare diseases. These are very common diseases. I want to talk about, what we have for treatment these days. That a lot of these things we didn't have 20 years ago. Some of them we didn't have 5 years ago or 2 years ago. And they asked me, well, you're talking about all of this. Can you talk about all the new investigational things? I said, no. That'd be 10,000 things I'm talking about. There's so many investigational things. I'll touch on things that are out there, but I think the new things that we're getting every day that we're using on a daily basis, many of you may not be familiar with. So I'm going to talk about those 4 common brain diseases. What are the symptoms? What are the signs? How do we know that a patient has those diseases? The pathology is very important. I did training in pathology. I'm not sure they even teach pathology in medical school anymore, but I think it's very important to know what's going on in the cells of our patients. Biomarkers. This is huge. 5 years ago, a patient would come and it's like, oh, do I have Alzheimer's? I say, well, your memory testing, suggests you might, your MRI suggests that you might, but we don't really have a test. We don't have a test. We don't have a blood test or a scan that we can do. That's all changed. Okay, now if a patient comes and they want to know, do I have Alzheimer's? We can tell them yes or no. We have biomarkers. What's a biomarker? Biomarkers are a test that you can do to know exactly what's going on biologically in the patient. And we just didn't have those in the past. That was kind of a holy grail to have a biomarker for Alzheimer's disease. We have biomarkers for Parkinson's disease that we didn't used to have in the past. And then I want to talk about, the therapies, which are changing literally every day. Pharmacologic therapies, there's so many. There's new ones all the time. Surgical therapies, immunologic therapies, and electrical therapies. If you have to have Parkinson's disease, I don't recommend it. If you have to have Parkinson's disease, the Bay Area is the best place in the world to have it. Between Stanford and UCSF, the advances in treating Parkinson's disease are just amazing. And it's really a collaboration between the innovative professors that we have coming up with new treatments who, it takes 8 months to get in to see them, and those of us who keep up with these new treatments and use them every day. It's still average of 2 months to get in to see a neurologist throughout the country. And that's about exactly where we are at Sutter, about 2 months. And that's even for patients who have real serious neurologic diseases. There is an access problem for sure. But we have so many cool things to treat with. And when I say cool, more than a neurologist, I say I'm a neuro nerd, because a nerd is somebody who's so passionate about something that they can bore the pants off of anybody for hours talking about it, and that would be me. So, let's start with Alzheimer's disease, which you're seeing stuff in the newspaper almost every day about Alzheimer's disease. It is the most common cause of dementia. So what is dementia? Patients always want to know, do I have dementia or do I have Alzheimer's disease? Which do I have, doctor? And I explained, dementia is not a diagnosis. Dementia is never a diagnosis. It's a symptom, okay? And dementia can be caused by a lot of different things. Dementia just means progressive loss of the higher cognitive brain functions. Not the basic things like movement, sensation, vision, but perception, judgment, reasoning, language, all these things that make us human. And pathologically, Alzheimer's disease has particular pathology in the brain. amyloid plaques, neurofibrillary tangles, which I'll get to in a second. But it often coexists also with ischemic vascular disease. And they overlap, they magnify each other, they make it harder to diagnose the patient. But it's also possible that patients can have Alzheimer's disease and Parkinson's disease together. So, unfortunately, one is not protective against the other. So an Alzheimer's patient has early and severe loss of recent memory, which progresses to the point that they can't remember things that happened 2 minutes earlier. Okay? So if a patient comes in and they have cognitive problems and their recent memory is completely normal, very unlikely they have Alzheimer's disease. Very common that they have logopenia, which is specifically they have trouble with nouns, not adjectives. It's interesting. Not verbs, but they have trouble coming up with the names of things. Oh, can you pass me that thing that has the salt in it? What's it called? But not nouns. There's other dementias where you lose, there's other dementias where you lose verbs, you lose sentence construction, but specifically nouns in Alzheimer's disease. They have loss of executive function. What's executive function? It doesn't have anything to do with, being a CEO. It's keeping track of plans and all the steps that you have to take to make those plans. It can be making a recipe. Why didn't this cake turn out? Oh, they left out the eggs. Why is the water heater all over the floor? Because they took it apart and they can't figure out how to put it back together. This guy called me up on the phone and he told me I should invest all my money in this, and I thought it was a good idea. Okay? Consequences, understanding consequences of actions. But in general, the rest of the neurologic examination is going to be normal in Alzheimer's disease. Walking, balance, sensation, vision, coordination. And it's standard to use the Montreal Cognitive Evaluation. The mini mental status, anybody who's using that, shame on you. Don't use the mini mental status, it's no good. Montreal Cognitive Assessment is very sensitive and tests all different parts of the brain. I can't really use a pointer, I guess. Oh, wait, do you see the arrow? Does that? No. Well, anyway. Yeah, but there's 2 screens, is the problem. Patients may become agitated. The basic personality of patients doesn't really change in Alzheimer's. Nice people tend to become nicer. People who are jerks become even more jerks. I have one patient who is just a wonderful person. She has a strong sense of social justice, which becomes a problem because in her nursing home, she sees other patients in there and their family isn't visiting them enough. She'll get in their face. You're not visiting your mother enough. And, it becomes a problem. So people's personality traits will often get magnified, but their basic personality doesn't change. There are other dementias where their basic personality will change. Now, if you look pathologically in the brain of a patient with Alzheimer's, on the left you see a kind of a normal-looking brain, and on the bottom you see an Alzheimer's brain. The brain atrophies because patients are losing brain cells. If you look microscopically, there's 2 characteristic things. Up at the top you see what's called an amyloid plaque, and this is a protein called A-beta, which polymerizes into these clumps outside the cells. And then in the dying brain cells, you see what's called neurofibrillary tangles. And that's a protein called tau, which is involved in movement of molecules inside the cell. And it becomes hyperphosphorylated and clumps up, and then the cell doesn't function, and it dies. So this is what we see pathologically. Now, I mentioned in the past, we would do memory testing, maybe some imaging, and we'd say, well, it looks like it probably could be Alzheimer's disease. But we'll only know after the patient's dead and we can look at their brain at autopsy. Now we have ways to diagnose abnormal amyloid plaque. We can do a spinal fluid examination, abnormal levels of A beta, phosphorylated tau. We can do a PET scan, which shows abnormal amyloid in the cortex of the brain. And recently, this has been our holy grail for such a long time, we have a blood test for Alzheimer's, a very accurate, very specific blood test for Alzheimer's. Unfortunately, insurance doesn't necessarily want to pay for it yet, because it's new, of course. But if a patient doesn't have to have a spinal tap, if a patient doesn't have to have radioactive material injected in them, wow, this is great. And we're ordering this a lot. And when people look at it, you know, and they look at like the difference between paying a few $100s for an accurate diagnosis blood test, people are going for that. And this is really changing how we do things. You've probably heard of ApoE, genotyping. That's a risk factor for sort of dementia in general, but specifically a risk factor for vascular diseases, cerebrovascular disease, cardiovascular disease. What do we have to treat? We have symptomatic medications. We have acetylcholinesterase inhibitors, been around for a long, long time, little bit of effect. We have memantine, little bit of effect. Now we have amyloid clearing medications, medications that can remove amyloid from the brain, okay? And there's been in the past two schools of thought. Is it amyloid beta or tau that's the main driver of dementia and Alzheimer's disease? The beta amyloid protein, people were called the Baptists, and the tau were the Taoists. So there's the Baptists and the Taoists. There's probably, you know, a little bit of both in there, but you would think if amyloid was really the answer, if you remove all the amyloid from the brain, you've cured Alzheimer's disease. Not the case. We have these very expensive, potentially dangerous IV medications, which can slow down the progression of Alzheimer's by maybe 30%, okay? Not a cure. And, you know, these are intravenous. Patients have to get them every 2 to 4 weeks. It's a big deal, and it's clearly not a cure. So we have a long ways to go for treatment of Alzheimer's disease. And the question is, if you remove all the Alzheimer's, or all the amyloid from the brain, what happens to the patients long term? We don't know, but there's no reason to think that if you stop this treatment, the amyloid's not going to gradually build back up again. So not a cure. But it's, you know, the first thing we have that can potentially alter things. Let's see, okay, yeah. Potential side effects, brain swelling, brain bleeding. Not real common, but we have to do frequent MRI scans, so that adds to the expense. So unmet needs, how do we prevent Alzheimer's? Because right now, when patients develop memory problems, we can diagnose it. We don't really know what causes it. There's some rare genetic forms. And we need effective and affordable disease modification. Ideally a pill, not an infusion, a pill that can stop the progression of cell loss and ideally restore function, you know, reverse the dementia. We don't have any of this yet, but there's new things every day. So let me go on to Parkinson's disease, okay? And if it seems like this is all very superficial, it is, because I only have 45 minutes to talk about all of these things. So Parkinson's disease, in medical school, they teach, it's a problem with dopamine-producing cells in the brain. Not true. There are numerous different types of cells that produce different neurotransmitters that are lost in Parkinson's disease. So it really affects the entire nervous system. It's not just a movement disorder. So dopaminergic, yes, but acetylcholine is affected. Patients get dementia, they get hallucinations. Serotonin is affected, sleep disorders, mood disorders. Adrenergic neurons are affected, so autonomic failure. As recently as about 20 years ago, in the academic centers, they said, oh yeah, Parkinson's is a movement disorder. And then about 20 years ago, the experts started publishing papers saying, oh, there's non-motor symptoms too, as though it was news to us, treating the hundreds of Parkinson's patients. So now it turns out that the non-motor aspects can be even worse than the motor aspects. So I'll get to that. So the motor manifestations that we see, that we think of in Parkinson's disease, is patients are slow. It's called bradykinesia or akinesia. They have stiffness of their muscles, cogwheel rigidity. They have tremor, which is a resting tremor when they're not doing anything. It often goes away when they do something with their hands. And they have balance impairment and falls, which is a major cause of death in patients with Parkinson's. You break a hip, you break your spine, and you may never leave the hospital. But the non-motor manifestations, my biggest focus now, just because it's the biggest need in my clinic, is Parkinson's disease, advanced Parkinson's disease. Hundreds and hundreds of patients. They become demented. They have orthostatic hypotension. They stand up, their blood pressure goes from 120 over 80, they stand up and it's dropped to 80 over 40 and they pass out. Constipation can be a chronic problem for years before they develop any other symptoms. Urinary incontinence, bladder dysfunction, anxiety is really hard to treat in Parkinson's patients. They develop visual hallucinations. They have a number of sleep disorders, and it goes on and on and on. So, visits with Parkinson's patients take a long time because I have to go through every single organ system in their body and treat every single organ system. So pathologically, what do we see in the brains of Parkinson's patients? We don't really see much on MRI, but there are abnormal inclusions. See that big pink thing with the arrow pointing to it? It's called a Lewy body. It's an abnormal accumulation of alpha-synuclein. And so Parkinson's disease and other diseases that have abnormal alpha-synuclein we call synucleinopathies. And there's basically three of them that we see. Parkinson's disease, Lewy body dementia, which are actually the same disease. Okay, they're different presentations of the same disease because Lewy body patients eventually develop a movement disorder. Parkinson's patients, if they live long enough, develop dementia. And then there's a fortunately rare disease called multiple system atrophy, which has really severe autonomic failure as part of the disease. And we don't really have any good treatments for multiple system atrophy. Excuse me. Now, biomarkers. It used to be most of the time we could diagnose a patient based on, they have cogwheel rigidity, they have a slow gait, they have impaired balance, and a number of other physical findings. But very early on, patients may have some subtle things, and we want to know, well, do they have Parkinson's disease? We now have biomarkers. We have tests that we can do to say what's going on biologically. The DAT scan has been around for a while. It tests the basal ganglia, the dopamine transporters, and it shows whether their dopamine system is normal in the basal ganglia. On the left, you see a normal DAT scan where the basal ganglia is lighting up, and on the right, there's a lot less activity in the basal ganglia, and that's typical for Parkinson's disease. But now we also can find on a cellular basis if they have abnormal alpha-synuclein. We can do a simple skin biopsy in the office, take a little piece of skin from the leg and the back of the neck, a couple of millimeters, and we can see, do they have abnormal synuclein? And if they do, they have a synucleinopathy. So we have biomarkers that we did not have in the past that make diagnosis very accurate. How do we treat Parkinson's? Now, the motor symptoms, there's medications and electrical treatments. Because remember, nerve cells are both chemical and electrical. They communicate with each other chemically, but the signals are electrical. So we can treat both chemically and electrically. Non-motor symptoms, I've got a talk that for an hour-and-a-half talk, very brief coverage of non-motor symptoms for an hour-and-a-half. I could do that now, but I don't think we have time. But briefly, orthostatic, we have a couple of medications specifically for Parkinson's disease. For orthostatic hypotension, we have a medication called droxidopa, which can increase the motor tone in the blood vessels and keep their blood pressure up when they're standing. Hallucinations, we have a medicine called pimavanserin, which is the only indication is hallucinations in Parkinson's disease. It's not used in any other disease. But as far as all the other non-motor symptoms, I'm not sure about AI. This is still an art. Treating advanced Parkinson's is still an art because there's so many things. There's so many things that are off-label that you can try. There's so many non-pharmacological things. I had a patient the other day. He was having trouble sleeping because his feet felt cold, which is important in Parkinson's. I said, go down to Daiso, get some of those fuzzy house socks, and you wear those to bed. And he comes back and he goes, wow, that really works. I said, the magical fuzzy socks. So it's still an art form treating the symptoms of Parkinson's disease, and that's what I do all day. That's what I love. And at this point, we don't have any disease-modifying therapy. This may change. There's a couple of different genetic markers for Parkinson's that they're starting to do gene therapy. We don't have any gene therapy for any brain diseases at this point, but that may change in Parkinson's disease as we're discovering different genes that cause the same symptoms. We may have treatments for those, but not yet. So pharmacotherapy, mostly it has to do using levodopa to increase dopamine in the brain. There's medications that can extend the effect of the levodopa, and we have ways, if patients are having absorbing them, to bypass the stomach. We can put tubes into their jejunum and drip the levodopa directly in there. The newest thing, and this is taking off really rapidly, this is less than a year old, is we have a subcutaneous levodopa pump. So it's just like an insulin pump. They put a little thing on their side, and there's a pump that they can come in and the neurologist can program how much levodopa they're getting, and they have a continuous, steady level of levodopa all day long. This is really taken off. I'm doing 2 or 3 prescriptions for this about a week now. It's going to be very popular. There's also a subcutaneous dopamine agonist pump. Dopamine agonists have a little more problems with side effects. Deep brain stimulation has been around for a while, and a lot of the great work in modern DBS is happening at UCSF and Stanford. So as I said, if you have to have Parkinson's, I don't recommend it, but live in the Bay Area because you're going to get the best treatment. This is now standard therapy, and for advanced Parkinson's. However, a lot of people think, oh, this is what you go to when the medicines don't work anymore. That's completely wrong. You will never be any better with DBS than the best you can be on your medications. Okay, so in other words, if you're not responding to levodopa, DBS is not going to help you. So the reason people get this is because the levodopa is wearing off. They take a pill, an hour later they've worn off, or they take a pill and the level's too high and they're dyskinetic, and then they go and they can't move. DBS is on all the time, but you're never going to get any better than you are at your best with medication with DBS. So electrodes are implanted. There's a couple of different targets deep in the brain, in the basal ganglia. And it's programmable. You can change, how the stimulation, where it is, how fast, how intense the stimulation is. It's very effective for motor symptoms, except for balance. We have nothing to improve balance in Parkinson's disease except Tai Chi. And I tell people over and over again, no, I'm not pandering to the audience. This is studied. This is absolutely studied over and over again. And I'll tell you, the people who are most resistant to doing Tai Chi are my Chinese patients. I don't know why that is. But Tai Chi makes an enormous difference. And exercise is just as important as medications. Okay? One without the other is not going to do the trick. So patients who just go, well, I'll just sit and watch TV and take my meds, it's like, you're not going to be walking a year from now if you keep that up. And, patients who exercise a lot, it's great. It keeps the function, but they still need a little bit more because they are losing brain cells. So both exercise and medication, very important. And deep brain stimulation can be really helpful because medications have their limitations as far as you have to take it in your body, and then it wears off, and then you take more, and it wears off. So, neurosurgery, Stanford or UCSF. Then they come to the neurologist for their programming. I've been doing DBS programming before they had programs at UCSF and Stanford, so about 25 years. I've seen all the iterations, and it's getting better and better. So unmet needs, disease modification. We have nothing to prevent the progression of the disease. We don't have treatment for the balance dysfunction except for Tai Chi. There's other things similar to that. There's a boxing class specifically for Parkinson's disease, and dance classes are very good as well. We don't have a good treatment for the dementia. We have some symptomatic treatments, and the autonomic failure often becomes the most disabling symptoms. Patients cannot get out of bed without passing out because their blood pressure bottoms out as soon as they stand up. Now, ready to go on? Multiple sclerosis, real quick here. It's an autoimmune disease, attacks of inflammation in the brain and spinal cord. Each attack will leave a scar behind, and the scar is called sclerosis. So they have multiple attacks. The attacks leave scars behind. Eventually, disability builds up. Okay? So initially, they may clinically recover from an attack, but eventually, disability builds up. Common presentations of multiple sclerosis. It can present in all different ways, depending on where the attacks are in the brain and spinal cord, but common ones, optic neuritis. The optic nerve is part of the central nervous system, so rapidly progressive loss of vision in one eye can be very painful in the eye. Usually recovers completely or almost completely in multiple sclerosis. Another common one is ascending numbness or weakness in one or both legs. So some numbness in the foot. Over the next few days, it's rising up. They can't move that leg. It's numb, and it goes up, and they feel like there's a tight belt around their abdomen. Diplopia, double vision, vertigo. That means they have lesions in their brain stem. So it can present in all different ways. Those are just some of the common ones. Associated features, fatigue, very hard to treat. Those signals are trying to get through those scars in the nervous system. The patients feel very fatigued, and it's not just feeling tired, and it's not just needing extra sleep. They're very sensitive to heat. That's purely an electrical phenomenon. The electrical signals have trouble getting through when the patient's body temperature goes up. Patients have to have air conditioning, and PG&E has a form that you can sign to get the patients a discount in their electricity. Cognitive slowing, boy, we don't have anything good for that. Bladder dysfunction, constipation, sexual dysfunction, and spasticity when people have progressive damage to the spinal cord. Low vitamin D levels are associated. We don't know exactly what the connection is. We used to think, oh, maybe the low vitamin D is part of causing the disease, but maybe not. But there are probably hundreds of different genes that can slightly increase the risk for MS, and many of those genes are genes that are associated in vitamin D processing. So patients can spend all day in the sun, their vitamin D level still be 7. So we always supplement vitamin D, and maybe people feel a little bit better, but it's not a dramatic thing. Oops. Okay, so right now, examination and imaging are the standard of care. We don't have a blood test. So our biomarkers are basically spinal fluid and MRI. So you can see numbness, weakness, clumsiness, but you have to have an MRI for diagnosis of MS. And we do blood tests to make sure it's not some other disease like lupus. Occasionally we do CSF exams, but we don't do those nearly as much as we used to because of advances in MRI technology that we can know very specifically what a patient has. So here's some examples. On the left, all the white spots are scars from current or previous inflammatory attacks. On the right is a spinal cord, and you see the same thing. The white areas are scars, sclerotic lesions with atrophy of the spinal cord. On pathology, on the top one, what you're seeing is axons, nerve cells. The red is the myelin, the coating of the nerve cell, which in areas is stripped off, so you see the blue underneath the axon, but you also can lose the axons. So you lose both myelin and axons, which lead to permanent damage. On the bottom, you see the infiltration of inflammatory cells, the dark blue inflammatory cells, usually around the veins in the brain. So since this is an autoimmune disease, all the disease-modifying therapy we have address the immune attack on the CNS. And there's multiple different ways, medicines against T cells, medicines against B cells, blocking lymphocytes being able to get into the central nervous system, general immunosuppression, things that immunomodulate, but all of the treatments we have affect the immune system. And they can be oral, they can be subcutaneous injections, they could be intravenous injections. And the choice depends largely on risks. Does the patient have underlying possible diseases? Are they at risk for getting shingles, or are they at risk for getting tuberculosis, hepatitis? So we check for all of these things. Side effects of the medications, and mode of administration. If a patient lives, 6 hours from an infusion center, probably an infusion medication is not going to be the best choice for them. Spasticity is a big problem in multiple sclerosis. We do have devices for that. We try oral medications for spasticity, but intrathecal baclofen can be very effective. We do have at Sutter a intrathecal baclofen clinic where patients are managed very well. And it's a pump, a refillable pump, which drips baclofen directly into the spinal canal and affects the spinal cord to relieve the severe spasticity that patients may have. And then they go in for refills of the pump, adjustment of the pump rate. Okay, unmet needs. We don't really understand what triggers the autoimmunity in MS. There's a number of theories, so we don't know how to prevent it. We don't have any way to restore function. You've got these scars, these sclerotic lesions in there. Can we get rid of those scars? We don't have a way of doing that. Is there a way to put the myelin back on the nerve cells? There's a number of trials underway for that. We don't have anything that's safe and successful for that. There is one medication that can improve the electrical conduction through the nerve cells that can actually help a lot with patients' fatigue. Potential side effects there. So we can't manage all the symptoms. And actually, Dr. Capizzi has a great talk on managing MS symptoms. But the cognitive deficits we don't have a good treatment for. I mean, the things we use for Alzheimer's disease and Lewy body dementia don't have that much impact on cognition in MS. So, I don't know where I'm at time-wise, but I told you this was a lot of information. 1 minute, okay. All right, well, real quickly, epilepsy, recurrent seizures due to abnormal electrical rhythms in the brain. There can be primary generalized epilepsy, which is a genetic disease, but most adults have localization related. In other words, they have a lesion where the seizures start, and most have no imaging abnormality. What we can see on the left side is a patient with a big brain tumor. Their seizures are due to the brain tumor, obvious. On the right side, very, very, very common disease in California, neurocysticercosis. And that causes lesions in the brain, and seizures are usually the first manifestation. But in adults, we mostly don't see any lesion. There is a driving restriction per California law. You have to submit a confidential morbidity report, and you have to check and see if the emergency room where they went for their first seizure submitted it. Usually they don't. There's a risk for accidental death, falls, drowning, never swim alone if you have epilepsy. Sudden unexpected death in epilepsy is a thing. Patients die in their sleep if they have poorly controlled epilepsy. Maybe it's due to cardiac arrhythmia, maybe it's due to apnea, sometimes we just don't know. There are mood disorders, increased risk of suicide. How do we diagnose it? We use the EEG. These are our biomarkers. EEG up on the top right shows abnormal electrical discharges. Sometimes on imaging we can see a abnormal structure in the brain. That's what's called cortical dysplasia. People are born with this, just abnormal formation in the brain. Treatment, the goal is patient is seizure-free and has no side effects. There's a lot of seizure medications. You often have to try different ones. If a patient has gone through 3 or 4 medications, they're still having seizures, they may need something else. So we have surgical treatments. What you see down on the bottom is they've exposed a patient's brain surgically, and then they've put a grid, an electrical grid to measure exactly where seizure discharges are coming from on the surface of the brain. The patient actually walks around with a bandage on their head for a few days with their brain exposed, and then they can find exactly where the seizure is coming from. If they can identify that, they may be able to go in and surgically remove that area of the brain that's causing the seizures. We also have multiple electrical devices. Medication-resistant seizures. I know my time is up, but I've only got one more slide after this. So, medication-resistant seizures, you can't resect the focus. It's in the verbal area of the brain, and the patient, despite medications, still having seizures. There's 3 things we have out there. We have deep brain stimulation, which is very similar to the one we use for Parkinson's. And that's the one on the left side, goes up and goes deep into the brain. There's what's called responsive neural stimulation, where there's 2 electrodes. There's one on the surface of the brain that detects the seizure, and then another electrode that fires to stop the seizure when it starts. So it detects the seizure and then stops the seizure. And then kind of probably the least invasive is vagus nerve stimulation, the left vagus nerve in the neck, not in the brain. You clip an electrode on there and it gives stimulation to the vagus nerve, which goes up into the brain and suppresses seizures. The new versions of this can actually detect an increase in heart rate. Sometimes people's heart rate spikes right before they have a seizure. The device can detect that, give extra stimulation to prevent the seizure when the patient's heart rate spikes. So a lot of great electrical techniques that we have now. So in summary, and one thing I just wanted to mention is a patient on seizure medicines always wants to know when they can stop. If they've had multiple seizures, they have epilepsy. Okay, a single seizure is not epilepsy. 2 seizures is epilepsy. 3 seizures, 4 seizures. And if they stop their medications, no matter how long they've been off, they're at risk for having seizure recurrence. So the goal is a medicine that doesn't cause side effects, but they have to stay on it. If they get off of it, you tell them, you can't drive for 6 months because you might have a seizure. So in summary, modern therapy, previously untreatable neurologic diseases, we can relieve symptoms, we can improve function, we can extend the lifespan because patients aren't falling and breaking their neck. We can improve quality of life significantly, but we don't have any cures yet. Unfortunately, we've got no cures for anything. They asked me to talk about all the emerging therapies. Do I have time? No. So I'm just talking about all the cool stuff that's come in the last few years for approved medical treatments, and there's a lot, as you see. There's a lot of emerging therapies. Gene therapies, I mentioned, they're studying some for Parkinson's. Stem cells have been less helpful than we had hoped that they would be. There's a lot of investigational treatments, but investigational treatments, some of them can be dangerous. A few years back, there was a big trend to put stents in people's veins in their neck to treat MS. People died from that at Stanford. Not through the neurology department, I'll say. Other things, there's giving people hookworm infections has an effect on multiple sclerosis. Not a lot of people lining up to be infected with hookworms. So there's a lot of investigational treatments, and some of them look promising, but we just don't know yet. And as I say, a lot of this is still an art, and we have AI, but I don't know if we have AA, if we have artificial art of medicine yet. And I've got some references. I'm hoping that some of what I said has stimulated you to want to look into it more. But again, this was a big topic and I just limited it to the brain. So I don't think we have time for questions, but I'll be around during the break. Thanks.
Thank you.
Okay.
It's really not fair. We ask someone so passionate and very complex topic, and we give you 45 minutes. You did great. Thank you.
Well, last weekend, every 2 years, I do a full-day conference on dementia, and we did that last weekend at San Francisco. So we had a little more time last weekend to cover that.
Yeah. Particularly with a subject like the brain, neuroscience, there's so much that's new, and it is very complex. And I just feel so blessed that we have this group of speakers to bring their expertise to us. It's amazing. And I want to reassure people online and in the room, you will get, like last year, a packet when the conference ends, and you'll have the copies of slides if the speakers agree to share them. So those of you that are thinking, I didn't catch it, you'll have another opportunity to do that. Okay, it's time for a break. So let's come back at 10 of. There are some muffins and beverages in the back, and it looks like a beautiful day outside.
It's still